Welcome to the deep dive. Today we're doing something really focused, specifically for your MSRA revision.
That's right.
We're digging into the source material, all those notes and articles you pulled together on one key topic.
Yeah, the idea is to pull out the absolute must-know, high-yield stuff. Cut right to the chase for rapid learning.
Exactly.
Oh.
And the topic for today is Henoch-Schönlein Purpura, or HSP. You'll definitely see this come up, so it's crucial for the MSRA.
Absolutely. It's the most common vasculitis in kids, but the exam questions often test the trickier bits, the variations, complications, maybe adult presentations.
Right, so our goal here is simple. Break down HSP into those unforgettable points. Definition, causes, symptoms, management, the works. Basically a shortcut to being really well prepared on this for the exam.
Consider it your high-yield briefing on HSP.
Okay, let's jump right in then. First things first. What exactly is Henoch-Schönlein Purpura? The material defines it as a systemic vasculitis.
Right, and vasculitis just means inflammation of blood vessels. HSP specifically hits the small ones.
Ah, small vessels.
Yeah, all over the body. And another name for it, which is quite revealing, is immunoglobulin of vasculitis. IgA vasculitis.
Okay, IgA, that hints at the mechanism, I guess.
Totally. We'll circle back to that. But the key features, the things you see because of this small vessel inflammation, well, there's the classic skin rash, those little raised purple spots, the purpura.
A palpable purpura, they call it.
Exactly. Then joint pain, abdominal pain, and importantly, potential kidney trouble.
And it's mostly kids, but adults can get it too.
Primarily kids, yeah, but definitely seen in adults, and that can actually be more serious sometimes, especially the kidney side of things.
Got it. Okay, so that's the what. Now, the why. Why does this happen? What triggers it?
Well, like a lot of these things, the exact cause isn't always pinned down, but we know it's immune-mediated. The body's immune system is kind of going rogue.
Reacting when it shouldn't or how it shouldn't?
Precisely. And there are several known triggers that can set off this reaction.
It's like infections.
Infections are a big one, yeah. Especially upper respiratory tract infections, like after a sore throat or cold. Strep is a classic one.
I see Streptococcus listed here, also Mycoplasma Epstein-Barr.
Yep, those are common preceding infections. But it's not just infections. Vaccinations can sometimes trigger it, insect bites, certain medications. Even genetics might play a small part.
And there's a note here about malignancy.
Yes, that's an important one, especially to keep in mind for, say, an older adult presenting with HSP without a clear recent infection. It's less common, but needs consideration.
So the immune system gets triggered by one of these things.
Yeah.
How does that lead to the actual vasculitis, the inflamed vessels?
Okay, so this is where the IgA part comes back in. The mechanism involves something called immune complexes. These are like little packages of antibody and antigens stuck together.
Right.
In HSP, these complexes specifically contain immunoglobulin A, the IgA, and these IgA complexes, for some reason, decide to deposit themselves in the walls of those small blood vessels.
Ah, so they sort of clog up the works.
Kind of. They lodge in the vessel walls, and that deposition triggers an inflammatory response right there in the vessel wall. The body attacks the complexes, but damages the vessel in the process.
Okay, so it's like debris blocking tiny pipes, causing swelling and leaks.
That's a pretty good analogy, actually. That inflammation leads to damage in the vessel wall, making it leaky, causing bleeding into the skin, that's the purpura, or inflammation in the joints, gut lining, or kidneys.
Which brings us to who gets this most often. Are there clear risk factors?
The main one is age. It's overwhelmingly a childhood condition. The peak age is typically between 2 and 11 years old.
Any difference between boys and girls?
The material suggests no specific gender predilection, seems to affect both fairly equal.
And other risks. I guess things like having those recent infections we mentioned.
Exactly. Recent infection is a big one. Maybe a family history of HSP, though that's less common. And possibly having other underlying autoimmune conditions might slightly increase the risk.
Okay. Now, let's really nail down the pathophysiology connection. We have the IgA complexes, the inflammation in small vessels. How does that directly translate to the symptoms we see? You mentioned the organs.
Right. It all comes back to where those inflamed small vessels are causing problems. Think skin, joints, GI tract, and kidneys. Those are the hot spots.
And there's a classic way it presents, often called a tetrad.
Yes, the classic tetrad. Not everyone gets all four, but it's the typical cluster. There's a helpful mnemonic, PAAR.
PAAR. Okay, what does that stand for?
P is for purpura, the rash. A for arthralgia, or arthritis, the joint pain. Another A for abdominal pain. And R for renal involvement. the kidney issues.
Let's break those down quickly. The purpura, what's characteristic about it?
It's usually the first sign, often starts itchy, maybe like hives, then develops into that palpable purpura, small raised reddish-purple spots you can feel. Doesn't blanch when you press it.
And the distribution.
Typically symmetrical, mostly on the legs, buttocks, maybe the arms. Usually spares the trunk.
Okay, and the A for arthralgia or arthritis.
Joint pain or actual swelling and inflammation. Usually affects the large joints of the lower limb, so ankles and knees are common. The good news is it's typically transient, it moves around, and doesn't cause permanent joint damage.
Right. Then the second A, abdominal pain.
This can be quite nasty, often colicky, crampy pain. It's because of the vasculitis affecting the vessels in the gut wall. Can come with nausea, vomiting, sometimes even blood in the stool if there's GI bleeding.
And the crucial are renal.
Yes, this is the one we worry about most long-term. It means kidney involvement. Usually shows up as blood in the urine haematuria or protein in the urine proteinuria.
How common is that?
The sources say it occurs in about 20 to 40% of cases. Sometimes it's microscopic, only picked up on urinalysis, other times more obvious. And the kidney biopsy findings, if done, look a lot like IgA nephropathy.
Which makes sense given the cause.
Yeah.
Any other symptoms?
Yeah, headache can occur. And in boys, scrotal swelling or pain is sometimes seen due to vasculitis there.
And the timing.
Yeah.
Usually comes on over days or weeks, often after an infection, maybe a bit of fever.
That's the typical story, yes. Often in autumn or winter, coinciding with respiratory virus season. Diagnosis is usually clinical, based on seeing that palpable purpura plus at least one other feature from the PAAR group.
Okay, clinical diagnosis. But this is where it gets tricky for exams in real life, right? The differential diagnoses. If you see a child with, say, a purpuric rash and tummy pain, what else must you think about?
Absolutely critical point.
Yeah.
Because some mimics are emergencies.
Top of the list.
Meningococcal sepsis, always. Purpuric rash, especially if the child looks unwell, think sepsis first. It's life-threatening.
Okay, rule out meningococcus. What else with the abdominal pain?
Intussusception, that bowel telescoping thing. It causes severe colicky pain, maybe vomiting, sometimes red currant jelly stool. And confusingly, intussusception can actually be a complication of HSP, but you need to identify it urgently regardless.
Wow, okay, so MSRA vignette time. Kid comes in, rash on legs, screaming with abdominal pain. Your immediate thoughts before settling on HSP.
Check for sepsis signs: fever, altered mental state, tachycardia. And have a high index of suspicion for intussusception. Maybe get an ultrasound if the pain is severe or localized. Rule out the immediate threats.
Right. What else is on that differential list? Maybe less urgent, but still important.
Well, other types of vasculitis need consideration, like Kawasaki in kids, or SLE, or even drug reactions causing vasculitis.
What about just a rash, like ITP?
Good point. Idiopathic thrombocytopenic purpura causes purpura due to low platelets, but crucially, it's usually non-palpable flat spots, and you don't typically get the joint pain, abdominal pain, or kidney issues like an HSP. Platelet count helps differentiate too. It's normal in HSP.
Yeah. Anything else?
Acute rheumatic fever could have joint pains and sometimes skin findings. Other connective tissue diseases. If kidney signs dominate, you might think of other glomerulonephritis. If gut symptoms are the main thing, maybe IBD. Oh, and acute hemorrhagic edema of infancy is another one mentioned. Looks dramatic, but usually benign.
So quite a few possibilities, but the key is prioritizing those red flags like sepsis and intussusception.
Exactly. Nail those first.
Let's talk numbers. How common is HSP? Epidemiology time.
We said it's the most common systemic vasculitis in kids.
Right, and the incidence figures are around 10 cases per 100,000 children per year in the UK, something like that.
Yeah, in that ballpark, maybe 10, 20 per 100K, depending on the study. It really highlights that childhood peak. 90% of cases are in kids, mostly between 4 and 6 years old. Very rare in babies.
And ethnicity.
Yeah.
The notes seem a bit contradictory.
They do mention both things. More common in children of Asian descent, and also Caucasians are more affected than other ethnic groups. It's possible different studies found different things, or it varies by region. We just have to report what the sources say.
Fair enough. And just to reiterate, adults get it less often, but when they do.
Often more severe, particularly the kidney involvement tends to have poor outcomes in adults. That's a key takeaway.
Okay. So we diagnose clinically using PAAR. We've ruled out the scary stuff. What investigations help confirm, assess severity, or monitor?
Investigations are mainly about supporting the diagnosis, checking for complications, and monitoring, especially kidneys. Urinalysis is non-negotiable.
Checking for that blood and protein. Haematuria, proteinuria.
Exactly. Needs to be done at diagnosis and then repeatedly for follow-up, maybe for months, because kidney issues can appear later.
What about blood tests?
Full blood count might show raised white cells or eosinophils, nothing specific though. Platelets should be normal or high, importantly not low, like in ITP. ESR or CRP, the inflammatory markers, are often up.
Kidney function.
Yeah, check urea and creatinine, UNEs, to assess kidney function baseline and monitor it. IgA levels might be high in about half of patients, but it's not a diagnostic test on its own. And maybe an autoantibody screen to help rule out things like SLE.
Imaging. You mentioned ultrasound for the gut.
Right. Abdominal ultrasound if you suspect intussusception or other significant GI issues. Barium enema used to be used more for intussusception. It could diagnose and treat it sometimes, but ultrasound is often the first step now.
Testicular ultrasound if there's scrotal pain or swelling.
Yep. Got to rule out torsion, which is an emergency.
And biopsies. Are they common?
Not usually needed for diagnosis if the clinical picture is classic. But a skin biopsy can confirm leukocytoclastic vasculitis with IgA deposits if the diagnosis is uncertain. A kidney biopsy might be done for severe or persistent kidney problems, like nephrotic syndrome, to guide treatment.
Okay. And you mentioned cancer screening earlier.
Yes, specifically highlighted for older adults presenting with HSP, especially if there's no obvious preceding infection. Worth considering an underlying malignancy as a potential trigger in that group.
Right, that's a good clinical pearl.
Yeah.
So let's move to management. How do we treat HSP? What's the approach, say, based on UK guidelines or standard practice?
The main message is that management is primarily supportive and focused on symptoms.
So making the patient comfortable.
Exactly. Rest, make sure they're drinking enough fluids, and manage the pain.
Pain relief. What do we use?
Paracetamol is usually fine. NSAIDs like ibuprofen can be very effective for the joint pain and even the abdominal pain. But you need to be cautious with NSAIDs if there's any sign of kidney involvement, as they can potentially worsen renal issues.
Okay, so check the urinalysis first.
Definitely. Check the urinalysis and kidney function before reaching for NSAIDs, or use them very cautiously.
What about more serious treatments? Steroids.
Corticosteroids, like prednisolone, are generally reserved for more severe cases. The evidence isn't totally clear-cut for preventing kidney disease, but they are often used for severe abdominal pain, especially if it stops the child eating or drinking, severe joint pain, or significant scrotal swelling.
So symptom control mainly for steroids.
Largely, yes, for the severe acute symptoms. Also considered for more severe kidney involvement like nephrotic syndrome or rapidly worsening function, often in consultation with pediatric nephrology. Other immunosuppressants are rarely needed but might be considered in very difficult or persistent cases. Things like colchicine or dapsone are mentioned as possibilities.
But for most kids, it's rest, fluids, maybe paracetamol, and monitoring.
That's the core of it. For uncomplicated cases, yes. Supportive care and watchful waiting, especially keeping a close eye on that urine.
Which leads nicely into prognosis. What's the typical outlook?
For most children, it's really good. The vast majority recover completely within, say, 4 to 6 weeks, maybe a few months, without any lasting problems from the acute illness itself.
That sounds positive. But there's a catch, isn't there?
There is, and it's the most important thing to remember about prognosis and follow-up. Even if the child seems fully recovered, there's a risk of developing chronic kidney disease years later.
Years. Even if the initial kidney involvement was mild.
Yes. That's why long-term follow-up with regular blood pressure checks and urinalysis is so crucial, often for at least 6-12 months, sometimes longer depending on the initial severity.
So the ultimate long-term outcome really hangs on whether the kidneys were involved initially and how severely.
Precisely. The severity of the initial nephritis is the main predictor of long-term renal outcome. End-stage kidney disease is rare, thankfully, but chronic kidney disease is a definite possibility that needs monitoring.
And again, worse renal outcomes generally in adults.
Yes, that pattern holds true.
Okay, so generally good short-term prognosis, but with that crucial long-term kidney caveat. What about other complications during the acute phase or shortly after?
Well, the kidney issues are the most common complication, affecting up to about half of children in some series, ranging from just microscopic hematuria to full-blown nephrotic syndrome or acute kidney injury.
And the gut.
Intussusception is the big one we worry about. It's a surgical emergency. Significant gastrointestinal bleeding can also happen. Bowel perforation is rare, but possible.
Any other system?
Much rarer, but because it's a systemic vasculitis, it can theoretically affect almost any organ. The sources mention rare complications involving the lungs, like pulmonary hemorrhage, the heart, myocarditis, infarction, or the central nervous system, seizures, stroke, neuropathy. Testicular torsion can occur related to the scrotal involvement.
So mostly kidneys and gut, but keep those rare ones in the back of your mind.
Exactly. Oh, and recurrence. It can come back.
How often?
Up to about a third of patients might have a recurrence, usually milder than the first episode and typically within the first 4 to 6 months.
Right. Okay, I think we've really covered the essentials there. We've gone through the definition small vessel, IgA vasculitis, the triggers often infections, the classic PAAR presentation, Purpura, Arthralgia, Abdominal, vein, Renal, the crucial differentials, sepsis, intussusception, key investigations like urinalysis, management being mostly supportive with careful use of NSAIDs and steroids for severe cases, and that critical point about prognosis good overall, but needs long-term renal follow-up.
Absolutely. These are the high-yield points you really need to have nailed down for the MSRA.
Anything else that stands out to you from this deep dive?
I think what's fascinating about HSP and important clinically is how something starting often quite simply a rash, some sore joints in a child, requires such careful thought about potentially serious complications, both immediate like intussusception and delayed like kidney disease. It really underscores the need to look beyond the obvious initial symptoms.
A really good point, thinking about the underlying process and potential downstream effects.
Exactly. It's a great reminder that seemingly straightforward presentations can have hidden depths.
Definitely a lot to think about there. Hopefully this focused run-through has helped solidify HSP for your revision. We hope this deep dive has been useful for your exam prep. For more free MSRA revision resources, visit freemsra.com. And for the full premium revision toolkit, head to passthemsra.com.